What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right, Kane. Today we have part 2 of our little series on cervical radiculopathy. Part 1, we talked about differentiating between extremity pain, spine pain. We talked about, defining radiculopathy versus radicular pain versus radiculitis, things like that. Today we want to talk about more so the treatment aspect, right? So the identification clinically of a radiculopathy and then how you go addressing it and helping the patient resolve their symptoms. So Kane, I'm going to throw it back to you to start off. I know you have a burning passion for this topic when it comes to identifying or quote unquote diagnosing radiculopathy, and this is in regards to the Wainner cluster. So Kane, start us off. Why don't you talk about this cluster?
Oh, man. So this cluster is drilled into your head if you're residency trained or if you're going to take the OCS exam. So the Wainner cluster is our current gold standard when it comes to diagnosing cervical radic. And it consists of a positive median nerve tension test, less than 60 degrees of ipsilateral rotation, positive Sperling's and distraction. And it is considered to be 95% specific if 3 out of the 4 criteria are met, and if 4 out of 4 are met, is considered to be 99% specific. So, like I said, currently our gold standard, it is the best thing that the evidence and research has shown to rule in cervical radic.
So what's the utility in performing this cluster, and whether you get a positive or negative, if the cluster is positive or negative, how is this useful in clinical practice?
I wish I had a good answer for you, Mark. I really do, because I never use it.
Right. So this is part of the reason, like you said, it's, you're studying for the OCS, you're taking residency, or maybe even PT school, you get this and it's kind of drilled into you. Oh, look, you can diagnose a cervical radiculopathy using this test. So yeah, like what for what purpose? What purpose does it serve?
So to me, this is something that is, if you don't know how to identify radic, if they just have neck pain and you're unsure, and then this is what you're coming up with, then sure, utilize it. If you don't have anything better, I honestly have no idea, because based off of our previous episodes of what Mark and I have talked about, how do we diagnose radiculopathy? It is through the history and through our objective testing, right? Yeah. If you are having a hard time figuring out cervical radic, if their symptoms are shooting down their arm, I don't know what else to say. I think you might need some more training in that regard. Like, you should be able to figure that out from the subjective alone. There's some trickier radics that are more isolated, or that you're just like, oh, it seems like a lateral elbow pain. It's a common one that we see, right? Sure, you may not get that from the subjective, but your objective testing should get you there. And this is one of those things where I think that maybe it can have some merit, especially if you're not familiar with repeated motions testing or utilizing MDT to help you diagnose and assess cervical radic. If you have something that's confusing, something that is isolated pain, something that you're just like, I don't know what it is, but it doesn't sound like neck, and then you test it, and then you use the Wainner cluster, you're like, oh, okay. Now we're getting somewhere. Now we're seeing that we're getting some of these positives in that criteria. Sure, you can absolutely utilize it. It's just not part of my practice, and I don't think that's part of Mark's practice either.
No. I mean, I remember learning it in school. I didn't know the name, and I didn't really remember it at all until you brought it up and then we decided to do an episode including it. But I think, like you talked about, the utility in diagnosing a radiculopathy and maybe even like recognizing it clinically. I just think, like, I don't know. I don't use it personally because it doesn't really change anything for me management wise, right? If someone comes in and they have spine pain, or they don't have neck pain and they just have pain in their upper extremity that I think could be radicular in nature, I have other ways that I'm going to see, or that I'm going to utilize within the objective and assessment portion of my exam to see if this pain is coming from the spine and if it's something that's going to be manageable from a PT standpoint. I don't know that performing this cluster is something that's going to provide me any kind of clinical utility, right? And there's even, like, I know, this they did research to identify this cluster, and then there's follow-ups using it where they have the people do a wide variety of interventions, everything from like manipulation to exercise, posture, traction, stuff like that. And they just find that the people that had a positive cluster, when you start to do that wide variety of interventions, like, some of them got better, some of them didn't. There's a large variation in the amount of improvement in this sample. It just goes to show, it's like, even when you have this cluster, and if you have it, like, there's research where they provided an intervention after on a population of people where it was positive, but there was like all kinds of different interventions done, and there was such a huge variability in the amount of improvement if there was any. So it's like, it doesn't really, there's not even really anything you could say that gives you any kind of guidance afterwards from a research standpoint in terms of what you would do if it were positive. Kane, you talked about...
So there's one more thing that I wanted to say, which is, if you have isolated neck pain and you're still also not sure of whether or not it is a cervical radic, or maybe it's a facet dysfunction or something like that, then I think that this could play a potential role. The issue that I have with that is, when you are trying to tease it out, is if someone has a facet dysfunction, you're still probably going to have a positive Sperling's compression and distraction test. You're also probably going to have limitations in your rotation as well, too. So use that cluster as you need to. I think it's a good starting foundation if you are unfamiliar with cervical radic, but I think that there are better ways to diagnose. And also, just like Mark said, the system that we utilize is not only an assessment method, but it also can function as a treatment method as well, too. So it gives you the steps that you need to go through to not only know what's going on, but then also to be able to help your patients get better. Like, this cluster, to me, doesn't really do a whole lot, because what are you going to do based off of these positive findings?
Yeah, and what if they're
nerve glides?
Yeah, what if they're negative? Right? It's kind of like, well, I guess it's not a radiculopathy, but I mean, yeah, right. You can go either way with this, and regardless, the clinical utility is low.
That's fair. That's fair. But I mean, the stats are there, and it's high. I think that's why it's considered to be the gold standard for a reason. Sure. But with this being said, I think that it is a low, like, skill floor to be able to apply and to be able to do this, versus using a framework which we use for repeated motions testing is a much higher skill floor and skill ceiling to be able to appropriately utilize it and then interpret it and then know where to go from there. But because it is more complex and intricate, I think that is where you have a lot more autonomy and options about where you're going to go. You just have so much more freedom about what you can do versus with the cluster. Like I said, are you going to give median nerve glides, or are you going to give snags for your rotation? And then does that fix the problem?
Yeah,
and I have no idea.
Yeah, and then do you do traction, and, like, do you just address each, or apply an intervention for each quote unquote positive, quote unquote special test, right? Is that the treatment? I don't know. I mean, there doesn't seem to be data to suggest that, but yeah, like you said, I think the other point to touch on, like, people can do the cluster, whatever. You can do the special test. That's fine. I don't have an issue with that. If it helps you with whatever management strategy you're going to apply. But I think when you talked about, the diagnosing aspect, I just don't know, even regardless of the experience of the clinician or what you're going to do management wise, just saying that someone has, and I think the way is that they define the radiculopathy was nerve root compression in these studies when they developed the cluster. It's I don't know, what does that give you? Are you able to provide the person with information? Like I said, it's just it doesn't really change much from a management standpoint. So it's, to me, I don't really use it. I guess I'm not really against it. I just don't know, I don't see a purpose in performing it when, like Kane said, we have other alternative assessment tools that we can use that can actually lead us down a route to proper management for people with radicular pain.
Yeah, I think that is probably my number one critique from what I've seen for the most part, which is you can diagnose it. You could have diagnosed it through just the history taking portion for the most part, but the management portion, how are you going to effectively and efficiently treat these people, right? This is a population where, to me, if you are just going based off of those deficits, you're taking the multimodal approach, which is A-level evidence in our CPGs, right? I think that following A-level evidence is usually good, but at the same time, if you're taking a multimodal approach, do you know the specific deficits that you're actually looking to influence and which one is actually causing positive changes? Or are we just throwing stuff up on the wall and hoping that something works, right? And this is where I think that Mark and I have mentioned this in our own discussions, which is that PT is a soft science. There is room for interpretation, for doing things differently. I am totally okay with that. But if you're just trying things and you're not being precise with what you're doing, I think that that's a problem for the field overall. And this is probably why Mark and I are so passionate about being very specific in controlling our variables, in making sure the intervention matches the specific impairment that we're looking to address, because that is how you become a better clinician. That is essentially how you become a better scientist, because you are looking to control all these things and make meaningful impact, and then realizing, oh, this is what works, this is what doesn't work, right? And with the approach that we utilize, we're able to do that. And that, I think, is why we continue to utilize McKenzie as a framework and to help guide us in what exactly we're going to do next. So I guess that kind of leads us to the next portion,
Cat's out of
which
the bag, man. You said it. You said the special word.
So we talked about how you can diagnose Radic, right? And the Wainner cluster is a good place to start, but I think that if you understand, or you take the time to understand and utilize McKenzie or MDT, that is where you can start to learn and understand a whole lot more about what's going on for their condition, what it responds to, what it doesn't respond to, and then also, just like Mark alluded to, how to best manage, right? So, Mark, how exactly do you utilize McKenzie when it comes to diagnosing Radic? Do you utilize what I talked about previously, which is just getting the history, or do you need to use repeated motions testing to confirm or to rule something out when it comes to this?
Yeah. So when you say diagnosing radiculopathy, right? I think I don't know offhand if I know for lumbar, we have some data that says if they have demonstrate directional preference or centralization, that we can hypothesize that it's probably a disc related type of pain, right? I don't know if it exists in cervical, but certainly when it comes to radiculopathy, if we go textbook definition and we're talking about a a loss in function, a decrease in sensation, decrease in strength or reflexes, something like that, right? I'm using my objective exam and the subjective exam to identify that. I think the more important clinical piece that I look at is if they have radicular pain that's from the spine that we will be able to manage, right? So when I'm approaching this from an MDT standpoint, I'm using repeated end range movements of their cervical spine to determine, okay, are the extremity symptoms that they have relevant? Are we able to change them with spinal movement? And are we able to provide a long-lasting change that the patient can change independently on their own so they can continue to manage what they're coming in for, right? So I'm not sure, or I'm not too concerned about the, like I said, the specific radiculopathy textbook diagnosis part. More so, okay, does this person have radicular pain that can change with movement, and are they able to manage it on their own? So that's where I'm using the repeated movements, end range movements, or the sustained positions when applicable.
Yeah, so I find that to be so interesting, and not to deviate from the topic too much, but I just think that this is a very important thing to kind of add in here. And we may have a separate episode on it, which is understanding why you're doing something. And I think that this is where MDT kind of gets a bad rap, because it's like, okay, what exactly does directional preference do? Like, what are we addressing? What are we treating? And I just had this conversation earlier, which is I don't really care what it's doing, like on a biomechanical level or anything like that, because just like what Mark said, we care about symptom modulation. Are we able to change symptoms based on spinal movement? And the thing is, the reason why I don't care is because if it works, right? And the big thing with something like this is if we are able to change a patient's symptoms, they are going to be so much more grateful than if we're just like, that disc bulge, that thing's gone, but you still have symptoms, right?
Right.
So to me, understanding those things, that's going to be cool. I don't think I'm ever going to see that or understand that in my lifetime. And the other thing is like, we've had these conversations before. We've told patients misinformation for decades, right? Like the conversation I had with Mark earlier was, for tendinopathy, we've told people we're realigning the fibers. We found out that that's not true. For subacromial pain or for shoulder impingement, we've been told that it's a closing of the space. People have done subacromial decompressions, increase that space. That's not true either, right? So like, it doesn't change their symptoms. And so what does it really matter about what is going on? Because what's the most important thing is you're changing your patient's symptoms. You're getting them to feel better. Sometimes you're fully abolishing their symptoms. That is the thing that is so important to me. And that is where I'm like, okay, this is how we dictate our practice, is by going based off of symptom response. And that is probably why it was one of our bigger tips in our previous episode.
Yeah, exactly. I mean, like if we compare someone being able to perform a cluster and then provide the information to the patient, hey, I think based on this that you have cervical radiculopathy, compared to if you're able to bring them through a movement assessment, demonstrate to them that when you do these kind of movements, your pain reduces or goes away. When you do these movements, it's worse. And then come up with a concrete management plan for that patient. I mean, I know what route I'm going each time. And I'm not saying, if you do the cluster, there's not any kind of direction management wise. It's just, I think there's a better way to do it than that.
Yeah, and I think that utilizing the two of them together is totally fine, right? Like if you want to use the cluster, which has a really high specificity, then that's great. And then you want to treat them with repeated motions or however you want to treat them, that's cool too. I just ask that you are able to manage their symptoms in an efficient and in an effective way, right? Like you want to make sure that you're giving your patients the best level of care that you can. And I say that as in like, I don't care what bias that you're coming at it with. Do whatever you want to do, but make sure that you're prioritizing the patient. right? Like you want to get the best results, period. Okay, so that enough on that tangent. So let's move on to the next topic, which is we're just going to do a brief overview of this because we've discussed it before. But just in case anyone who hasn't listened to that previous episode, we're going to talk about when to know it's spine and when to move on. So Mark, why don't you tell us what are the first few steps that you go through when you're trying to determine if there's spinal contribution to extremity pain or any of these radicular symptoms? And then how do you kind of navigate through that?
Yeah, so it's going to start subjectively, right? We've talked about the XPOS criteria and that, if they have change in symptoms with posture change in symptoms with flexion or extension of the spine, they have presence of numbness or tingling, they don't have restricted extremity movement, those kind of things. If they don't have any of those indicators coming in, it's much less likely that they have spinal contribution to the extremity pain. Moving on from subjective, I'm looking objectively. This is another criteria. If they have loss of movement in the spine, that's another. I'm looking at that objectively. Okay, this could contribute to it. And then I'm looking at their extremity, that the effect of the extremity where they have symptoms and they don't demonstrate movement loss there. Okay, maybe it's on the extremity problem, right? So those are the big things I'm looking for, right? So clearly, if some quality of symptoms, numbness and tingling, that's there. If they can have pain just at rest without moving that extremity, and I don't really see movement loss or issues with the extremity, another big thing I'm thinking of, okay, now I really am thinking I should investigate the spine. So a couple easy things you can pick up on subjectively, real easy things to look at objectively in terms of just range of motion, right? Did they have loss of movement in the spine? Do they not have loss of movement in the effective extremity? So I keep it pretty simple in that regard. Like I said, I mentally have a checklist with the XPOS study criteria or the indicators that the pain could be a spinal source. As I'm asking them questions and watching them move, I'm going through that. But that's the main thing I look at. Yeah, and then from there, go through my repeated stuff like that, looking for long signs of derangement that they demonstrate a lasting decrease in their symptoms in response to these movements, that kind of stuff. But yeah, it's all, it starts with the subjective, and then when we go to objectively, I'm just having them move.
So I think one of the biggest tidbits that I could really say for utilizing repeated motions or at least investigating the spine is to be patient with it, right? Sometimes you're going to get what we've called Cadillac changes, and that's awesome. Sometimes you could fully abolish within that session. That's amazing. That tells you are on the right track, right? Other times it just takes more time, let your exercises do their job, right? So you want to make sure that you've given them the appropriate dose, the appropriate amount of time, and then also just making sure that your exercise matches the deficit that you're trying to hit. So for us, if we're seeing that they're responding positively to retraction or to extension or to whatever it is that they need to, that they're responding to, we need to make sure that their exercise reflects that we aren't just flexing someone when that is like not helping them, right? So we need to be mindful of the interventions that we're giving to our patients and just making sure that they fit the criteria that we're looking for them to match with. So I guess my next question for you, Mark, is how do you know when you've exhausted something that's regarding the spine, and then when to look to the extremity to help treat that?
Mm-hmm. Well, like with MDT, there's a systematic approach, right? We start with patient-generated forces, we go to clinician-generated forces, and then the end result of those clinician-generated forces would be mobilization, right? So if we've gone through our sagittal plane movements and we've gone through the full force progression, we've explored laterally, we've looked at force alternatives, having them in lying, offloading the joints. We've gone through all of that, and we're not demonstrating a lasting positive change, or in some cases, you're not getting any effect on the extremity symptoms at all. It's probably time to move on, right? You've given it some time, at least like a couple visits. You're getting the end range. the patient has been diligent about their home program and the advice and recommendations you've given them in terms of monitoring symptoms and completing their exercise, yeah, it's probably time to move on, right? So then we go down the extremity. If we start to see things in the extremities such as loss of extremity joint movement, maybe they have a consistent production of their extremity symptoms with resisted movements that's unchanged with spinal movements, things like that. And then we're starting to look towards the extremity. Yeah. So like when we're looking at the McKenzie style approach, you're just making sure you're getting to the end range. You're testing out every movement when it comes sagittally, when it comes and looking laterally, when, especially if we're not getting a response. And then if you've really gone through that, and like Kane said earlier, you've given it some time, the patient's been doing their program as you've recommended to them, and it might just not be there. That's fine. It's time to move on. But I think it's important, like Kane said, you got to give it some time. You got to make sure the person's doing the exercise correctly. You need to make sure you've gone through the progression as described in terms of the forces provided and the directions and movements that you're exploring.
Yeah, I think to add on to that, one of the big things that I'm noticing is if there is contribution from the spine and the extremity still has an actual issue, so two problems going on concurrently, what I'm typically noticing is when I've screened the spine and exhausted it, keyword is exhausting it, is their range of motion is usually restored. It's going to be better than what it was previously, right? Maybe they're still going to have some limitations depending on their age group or anything like that. But for the most part, it's going to be better. The other thing that I'm usually finding is you're just going to get no effect, right? Like I'm usually, as I progress them over and over and over again, it's just no effect during and after. And so it's just like at that point, you've restored range of motion. You're no longer getting any changes in their symptoms that come from spinal motions. So, and given that you've gone through cervical and thoracic, etc., right? I think that is where you can confidently say, okay, probably don't need to go down this route anymore. But with that being said, it is very feasible, and we've talked about this previously, where you have to go top down, and I say top down as in spine to extremity, and then sometimes you have to return bottoms up, where you go spine to extremity, back to spine when there's a plateau, when you've exhausted the deficit that you're investigating, right? So there have been plenty of cases where I treat spine and it's like, okay, we got an improvement, plateau. We treat the extremity and then we make progress, plateau. And then I'm like, things just aren't adding up. Something is missing here. Does it need more time? What exactly does it need? I give it that time. I give it the reps that it needs. And then after that, when things don't match up, I'm like, this is still telling me something's there. I've returned to spine after treating the extremity and everything goes away. I'm like, wow, I don't know how that happens or why that didn't go away in the first place, but here we are. Don't be afraid to have to reinvestigate something if things just aren't adding up. You don't always have to do it, but when it's there, sometimes you gotta take a second look. And I don't know how many cases you see like that, Mark, but it's definitely something that I continue to kind of be skeptical about, where I'm like, okay, things just aren't adding up. We should reinvestigate.
I mean, maybe it's not like a huge amount of cases, but this speaks to the power of this tool and that as an assessment process, and that can turn to a treatment, right? It's like, we don't know, why this happened. We don't know why the symptoms have presented this way. And, it said maybe you had to go extremity, come back to spine. But what we do know is that we can use this reliable, consistent, standardized tool to continually assess and reassess different body parts or body regions to gauge symptomatic response, and then we can guide the treatment based off that symptomatic response. It's like you said, Kane, it's like maybe it goes back and forth a little bit. I don't know why it happens. Is there like a anatomical explanation for it? I mean, it's anyone's guess at that point, right? But as I said, we have the standardized process that we can use to assess and treat based on that response, and you can always go back to it.
All right, so that brings us to the next topic, which Mark has alluded to in his previous sentence, which is treatments. That's the whole point of this episode, right? So we have half the time left to discuss all of the potential treatments that we have. I will say, and I will preface this, most of our treatments are going to be MDT based. So if you are an MDT practitioner, I'm sure you're going to love this, because these are almost all the clinical pearls.
And if you're not, you're gonna learn to love it.
That's true. That's true. So like I said, these are all the clinical pearls that I've learned from my own practice or just from my conversations with Mark, because Mark is the resident MDT expert here, as he is credentialed and I am not. But starting off, I will say, for people who are unfamiliar or maybe not quite as accustomed to utilizing the system, is when you're treating cervical, my first tip is restore retraction. This is something that Mark told me earlier, and this completely changed my practice, which is you need to ride out the retraction force progression. Don't switch to do random things because you're not getting what you want right away. Make sure that you take your time with it and see how it's going to improve, right? Like, go through the entirety of it. Be patient. It takes time, especially with some patients who just have really stiff necks, especially if they've been having their symptoms chronically.
Yeah, right. Like you talked about, how do you know when to move on? How do you know you've exhausted a movement? Well, I got to mention this first. People, I still don't understand this, but people will use the word chin tuck interchangeably with retraction, but then when they talk about like a deep neck flexor exercise, they'll also call it a chin tuck. So when we say, can I say cervical retraction, we're talking about upper cervical flexion, lower cervical extension, and even with that kind of movement where you're moving your head straight backwards, you're going to get a little bit of upper thoracic extension as well. It's a big combined movement of the cervical spine and some thoracic contribution. So it's not just that chin tuck, that capital flexion, if you will, where we're not focusing on lower cervical extension. It is moving your head straight backwards as far as you're able to. So people say chin tuck. It's not just tucking your chin. It's moving your head backwards. Okay. But when it comes to exhausting that, right, there's the patient giving theirself force straight backwards on the chin. There's the clinician adding it. You can mob in that position, right? So there's more to it than just that small movement, right? So if you've tried to utilize these MDT principles and you've tried retraction and you've really just been doing a chin tuck, no, it's, you had the movement is trying to move your head straight backwards, right? It's, right. We're looking for those end range movements to really know if there's a response or not. You got to get the end range. You got to retract, not just tuck your chin. All right,
the other thing that I think is so important with what Mark said is you need to pay attention to the quality of the movement too. How are they moving? How are they performing their retraction? Right. And I think it's really interesting because I will tell my patients, tuck your chin, because they are essentially extending and retracting simultaneously. And you can see that they're just running into themselves. Like, it's unpleasant. It's a pinching kind of sensation. And they will always report this. And one of the things I tell them, tuck your chin more and then go straight back. And I usually have to guide them with this so that way they know what it should be like, where their head needs to go. And also, when you give them a little bit of pressure, they know how far they should be going. And every single time,
yeah, exactly. What do you?
My patients will be.
Sorry, I finished that. Go ahead. What do you say when you say running in? Like, explain what you mean, because I know what you mean when you're talking about, getting to neutral with the chin and then retracting from there. But like, what's the patient going to feel, and what are you going to see if someone's not getting, they're getting maybe that mid or upper cervical, or sorry, more like mid cervical extension rather than that lower cervical extension where that we expect to see as retraction and range of motion is being restored.
Yeah, so you can immediately see that their retraction, if they are having some extension moment during it, they are going to be pretty short on their retraction range of motion. It just doesn't go far because essentially you're just jamming your facets together when you do that. It's not pleasant. Like I said, it's pinchy, it's painful. You're not going to get to the end ranges that you're looking for, right? So that is typically what we're seeing is if I correct that, then they start to get differences in their symptom presentation. I don't correct that. Nothing really happens. They just get really sad because they're like, my neck just hurts after that. I'm like, now I see why. But what I was going to say is when I usually cue patients and give them the pressure that they need to show them this is how far you should be moving, they usually will say, oh man, I feel it in my neck and I feel it in my back too. There have been patients that have even pointed to like their upper lumbar or even like their lower thoracic, and they're like, I feel it all the way down to here. Is that normal? I'm like, for some people, yeah. If they don't move a whole lot and they're finally getting motion throughout there, yeah, you're gonna feel it. Right. And that's where, like Mark said, it is a big movement. It is not small. If you're moving the way that you should, like you're going to get motion all the way down. Wherever it stops, that's a different story. But you're going to get thoracic motion as well too, typically. So that kind of leads us to our next point, which is don't forget to look at thoracic. If you're having cervical symptoms and you're having upper extremity symptoms, depending on the area, don't forget to look there because like we said, your thoracic extension is going to contribute to your cervical motion, right? Sometimes, and I'm sure Mark can attest to this as well, but there are some times where you get someone to move and their neck just won't retract because they're so limited in thoracic extension.
Yeah. So yeah, for sure. Like you talked about the bottom up type approach when it maybe came to radicular pain and maybe address the extremity, come back to the spine, things like that. But if we just look at the spine, like sometimes they're not going to be able to get, if they're stiff enough and their head's just kind of in a certain position and they can't get retraction movement, you might need to start bottom up. So you have them start doing a thoracic extension type thing over a chair, and then those more caudal segments start to loosen up, and then they can start to work their way up, and then maybe their head's more upright, they're more in that neutral position, then they can start to retract, right? So if you're not like, let's just, for example, someone who's forward head, maybe they've lost enough extension mid and upper cervical where they're just kind of looking down, like that person's not going to be able to retract. You're going to need a bigger type of extension moment, which can come from thoracic. So you start getting them moving over the back of a chair. They start to open up a bit more. Their head's a little bit more upright. Then they can actually start to retract from there. So I want to say too, like we keep saying about emphasizing the quality movement, lower cervical extension, getting that range back. We're emphasizing that because in cases of radicular pain, it's typically the reductive movement that helps is retraction and sometimes adding extension to it, right? So in order to get the most amount of movement there, you need those lower cervical segments to move in order to get to the end range of that movement. So that's why we keep mentioning that. But yeah, sometimes if that's just not moving, you're not really getting anywhere with retraction, and you certainly can't extend from cervical to get those lower cervical segments if you don't have the retraction range. You might have to look somewhere else, and in that case, thoracic usually can help people begin to restore the retraction range of motion if they're not able to start with retraction.
Yeah, I think that with that being said, when you're going into thoracic extension, there's definitely a few ways to do this. I found that depending on where I'm seeing limitations, you can definitely make adjustments based off of like how they're positioned and sitting, right? Like, so Mark used the example of doing repeated extensions over a chair. And I find that usually helps a lot of people when it comes to their mid thoracic. But for upper thoracic, I may do something that is not exactly MDT based, right? So your classic exercise, your butterflies to address your CTJ, where your hands are clasped behind your head and you're just opening up your elbows as far as you can go, that is going to help improve your cervical thoracic junction, that mobility right there. There are a couple of other positions that you can go into to help address that position. But I think that this is something that just doesn't really get talked about a whole lot for people who are trying to kind of dabble with MDT. But remember that you can look to get I don't want to say specific segments, but specific areas of the spine to move better. You're essentially looking to bias how much mobility you're getting out of a specific area. And I think that is going to play a large role when it comes to the movement quality and how that contributes to your cervical spine movement.
And another benefit of restoring the retraction range of motion also comes when we look in the transverse and frontal planes, right? So especially from the MDT standpoint, when we're looking to add rotation, we're adding lateral flexion, the first step you're doing is getting upright and getting into a neutral retraction position. If someone can't get to neutral, and we've all seen this in PT school, you put your head forward and try to turn your head, you can't do it as much. If you sit up as straight as you can and rotate, you have more movement. So if we're looking to get to end range lateral flexion, or we're trying to get to end range rotation, and we find that there's a lateral component to the symptoms they're coming in for, then we need at least neutral retraction range, right? So it's just important to start with retraction and at least get to neutral, especially when you're going lateral. What about different positions, force alternatives, Kane? What are they, and where do they come into place when addressing radicular symptoms?
Oh man, I think the big thing, this is where I was saying that I used to make the mistake of going retraction into extension too quickly, which is a force alternative, right? And I think that when you take your time to restore retraction, that is going to do you the most amount of good for the most amount of patients. What I'll say is sometimes that doesn't fully resolve things. So force alternatives do exist for a reason. If I'm seeing that someone is still lacking the lower cervical and upper thoracic extension that I want them to get just from the retraction, that is sometimes where I've restored their retraction back as much as I can get. And then I start to add in that extension. And that's where I think that that's totally appropriate, given that they've plateaued and they're no longer making progress with the straight retraction force progression. The other alternatives that we have for something like this, obviously sustained is an option, but the other common one that you'll typically see is going supine. Man, this one kind of drives me nuts because I used to go supine more often when I didn't utilize retraction as much as I do now. And I think that this is a trend that I see really commonly, which is people are not getting the symptomatic response that they're looking for, or their patient may just be more irritable and they jump right into supine without actually giving the retraction force progression a chance. And I think that a lot of times when you jump into the supine version, you actually end up flaring up the patient a bit more because of how aggressive it can be. If you're jumping the force progression, this is probably the most I think arguably the most range that you're going to be getting your patients into, because now you have gravity that's kind of shoving their head back too.
I mean, definitely when you're looking at a retraction progression in supine, and especially if you add extension, like, I mean, you have gravity working with you, and it's a lot of range. Even though we can offload in the cases of someone that has high symptom irritability, and that can be beneficial and a good starting point. If you're adding the retraction force progression, and you are kind of just doing it for the sake of doing it, it can be a lot.
Yeah, and I think that for these patients, what I'm noticing is if they're not responding to retraction at all and sitting, that's when I start to move them into supine. And I still go through the force progression here. I don't really skip a whole lot of steps unless I am just like, this is spine. I need to prove that it's spine. Then I'll skip some steps. But for the most part, I'm still making sure, like, hey, what's your symptom response like here? Does laying down alone do anything for you here? Like, some people are just so hypomobile, they can't even lay flat. So that's where it's like, okay, maybe this is something that we can work with. Maybe this is something that they need. Maybe they need a little bit of distraction to clear out some more room for them to continue moving, right? Like, these are things that you can definitely continue to play with, but I would say make sure that you are exhausting the retraction force progression in sitting first before going to any of the alternatives. That is probably the biggest thing that I've noticed. What about for you, Mark? What are you seeing for supine or any of the other force alternatives?
Yeah, I mean, there's certainly some cases where supine's warranted, usually higher symptom irritability, or I find too, like, if someone, like, a way to get that retraction range back, or, if someone just can't do any retraction sitting because their symptoms get worse, you can accommodate it with a pillow, couple, 2-3 pillows, and they can retract essentially in a relatively flexed cervical spine, get them flat on the table, and then you can set them up and see how they do with the load of gravity on their head. But I certainly don't jump there. I think even from like a compliance standpoint, right? Like, how many people are going to be able to lie down throughout the day and do, right, like an unloaded lateral flexion rotation, right? It's just not, I don't know. I think it's harder from a compliance standpoint. So I try and keep people sitting when we're doing that. And then I don't find a lot of people need to go supine. Like you said, Kane, like, yeah, it's an alternative. It's there if you need it. I don't think, people may jump to it quickly, unless it's specifically indicated or warranted. If you've gone through your full progressions in sitting, or you feel like the symptom irritability is too much and you got to lie them down, try and stay sitting.
Yeah, I think that's probably why a lot of people go straight to supine faster, is because of the symptom irritability, and they're just afraid to test out the retraction force progression all the way through. It's just because they're in pain. I don't know what to do. I don't want to go here, right? So I think that is probably the biggest contributor to, I don't want to say the misuse of it, but why it seems to be a little bit more prevalent. All right. So the next topic the next tip that we have is looking to go lateral. Okay. So this is something that Mark and I talked about previously for the lumbar episode, where it's like, okay, look at lateral when things just aren't really matching up. For cervical, what we've tended to notice is that going lateral faster is usually going to create we've gotten more results out of moving lateral faster compared to doing so for the lumbar, right? So the biggest indicator for us is if they have unilateral extremity symptoms. That is probably one where it's like, okay, you went through your full retraction force progression and you're kind of getting nothing, or you're getting some like yellows and mild greens, but nothing is sticking. So that's where I think that it's okay for you to go lateral pretty quickly. So, Mark, there's two main lateral motions, right? There's retraction with lateral flexion, and then there's retraction with rotation. And there's also like pure rotation and pure lateral flexion as well. I don't see those quite as often, but what are the heavy hitters here that you would recommend people take a look at?
Yeah, I mean, I think I use lateral flexion more than rotation, and especially the lateral flexion with the clinician generated forces. I find just people can just tolerate it. The one other indicator I notice when it comes to adding these lateral forces is based on the symptom location. So if we're looking at lateral flexion and we expect that most of that range is going to be coming from the mid-cervical spine, right? We're looking at more of like a C4, C5 radicular presentation pattern, right? Similar to rotation, we're looking at more that upper cervical, right? So like C2-ish, maybe like the occipital type pain, headaches type thing. So that's another thing that can indicate that just based on the symptom location that you may need lateral forces to address them. I just think your standard rotation, and then I think the lateral flexion with the clinician overpressure and the mobilization seems to give people a fair amount of benefit. So I think being familiar with that and practicing it is beneficial. But yeah, I like that's the thing with this system. It's just like there's nothing like too complicated about it. It's just knowing when you have something and then knowing how to manage it. In this case, we're talking about these lateral components, maybe these unilateral symptoms, and then so you can base off the symptom location as well. I mean, so the process is the same though, right? You're exhausting your sagittal plane movements. If you're not getting the lasted benefit or you feel like you've exhausted it, then you move lateral, right? And then you can start based on your symptom location. If you think it's more of an upper cervical, you can go rotation based. If you think it's maybe mid cervical, maybe like kind of like lateral arm-ish, posterior shoulder pain, yeah, you can go lateral flexion. So I think that's a good starting point for people who are maybe not too familiar with the system.
Yeah, and I think it's actually really interesting for something like this because we talk about going into extension. We talk about going lateral here, for example, and this isn't specific to just MDT, right? When people mob, there are specific glides that you can do. You can do CPAs here, right? And that's essentially just pushing something to go into an extension moment. Awesome. You can go lateral. You can go into your side glides for cervical, and you're essentially just going based off of symptom response still. Mm-hmm. So this is not something that is just MDT based. There are other ways to continue to get results, but all we're saying is just go based off of their symptom response. That is the big thing. And right. There are times where like I'll break the force progression if I need to like see, okay, if I mob this, is there a change? If there's no change, then it doesn't really matter what system I use because we're doing the same thing. But maybe they just need more force. And if that gives me a change and then I can use repeateds after, that's awesome. But that's just how I utilize both practices. I just follow the framework and then just go on from there and just see if I can match the intervention with their symptom response to get them that lasting relief.
For sure. Yeah, like you talk about, it's all just about what's happening, how the patient's feeling, the symptomatic response, and if the person's able to self-manage with the symptomatic response that was demonstrated in the clinic. So you mentioned other kinds of treatments, right? We talked about MDT, we talked about the standardized process, looking at movement, gauging symptomatic response. And like you said, there's other ways you can do this, right? So are there any other kind of methods or like any other kind of presentations you see commonly with people with radicular type pain that may be coming from the cervical spine? And if so, what have you seen and what kind of methods or treatments you use to address these?
I will say that for most radicular symptoms, I don't see a whole lot of other treatments being super effective, at least in my practice. And this could just be because I'm comfortable and confident using MDT as my primary tool, but I just don't find that the other ones are quite as effective. The only other one that I do find to be effective are snags, which I think is hysterical because we talk so much about like going against standard practice in a way, but there's nothing wrong with these exercises, these standard exercises, as long as you have good justification for them, as long as you're going based off of symptom response, right? If someone responds to rotation, or if they respond to side bend, or they respond to pure extension, give them a snag. That is essentially the same thing. This is why I'm like, MDT is not just a list of exercises that you can do. You're just matching things based off their symptom response. So use your snags if you need to. If you're getting that symptomatic response and they're getting better, run with it. Maybe it just needs to move a little bit better. You get the facet less irritated, whatever it is, the nerve becomes happier, and then boom, you happy look nerve. Like a magician.
Yeah, and there's it's not like MD. I think this is something people get confused about. Like MDT isn't the movements, right? There's no system that owns cervical lateral flexion or cervical retraction, right? It's just about MDT is the assessment. Now, you can take any other systems, like you're talking about snags, right? Like Mulligan, yeah, like look, you're performing a technique, you're addressing in this case, a mobility deficit. You're looking to see if the person can move better and feels better afterwards, and then you're teaching them how to do it on your own, right? It meets all the criteria that we talked about that a good system should have, right? So there's multiple ways to do it. As long as you're looking at the symptomatic response and the person's able to manage it on their own, you go with it. So like Kane's saying, primarily we're using MDT. I also use snags. I think they're good, right? Especially if you're like, if it's something that's not exactly, not that it's not fitting, but if you're not getting the desired response from the typical repeated movements, here's another option you have. What about Kane? Like, go ahead.
I was just going to say, like, if there's a deficit in regards to someone's symptoms, make sure that you're addressing it, right? Like, just because like a deficit exists doesn't always mean that it's relevant. But if it is relevant, make sure that you're addressing it. It doesn't always need to be a repeated motions. It doesn't always need to be MDT, like how Mark and I utilize it. If there's something that's contributing to their symptoms, you have to make sure that you're hitting it. Otherwise, they're probably not going to be resolved in regards to their symptoms. So I guess that kind of brings us to the next potential intervention that we can utilize, which is motor control.
Don't say it.
Oh man. So I love motor control when it comes to extremities, but when it comes to the spine, it is not something that I typically see utilized. This is one of those.
You're not busting out the blood pressure cuff and having them hold their head at this many millimeters of mercury and doing it for 80 seconds and only using these muscles. What? Come on, dude. That's realistic. Come on, you can do it.
Oh my. It's just one of those things where it's just like, it's in the CPGs, it's in the treatment-based classifications. Most of the times these people fit into a clinical picture. They're usually hypermobile. They may or may not have some connective tissue disorder, right? Like EDS or anything along the lines of that. I think that for these people, if they are having a hard time sustaining positions, right? Maybe they have a headache because of this, then they might fit into this. I think that the testing criteria to fit into an actual motor control issue is just not good, right? Like you talked about the blood pressure cuff test. You can use the deep neck flexor endurance test, right? These numbers are all over the place. Sure, there are norms and you can definitely utilize it, but I think that the testing is just so subjective that it becomes hard to really say whether or not it's actually working. And the other thing is maybe it's just a reconditioning. Maybe you're just getting those muscles to get used to working again. Like I have no idea in that regard, but I never utilize motor control exercises when it comes to treating radic. If someone has localized neck pain and it's muscular in nature, I'll take a look for sure, but it is not my go-to when it comes to radicular symptoms. Do you ever utilize it in your own practice?
No, I don't think I've given it in maybe like 5 years, honestly. It's just, I just find radicular pain from the cervical spine is just, I think the MDT even works better in cervical than lumbar, at least what I've seen clinically. It's just, I can't really think of cases where it hasn't yielded positive results. I mean, sure, there's been people who haven't responded, but then usually, like we talked about, snags, mobility deficits, usually I don't really see the motor control presentation clinically, unless, like Kane said, maybe they have a connective tissue disorder or something like that, where it's like, okay, this person has a lot of movement. They need to learn how to control it because they have some other tissue pathology. Apart from that, I don't really see this presentation or the need to prescribe the motor control type exercises.
Okay, so the next topic or intervention is postural exercises, different shoulder or periscapular exercises. So, Mark, what exactly is your thought process when you're utilizing this? I think that.
So, you think. What do you think? What do you think, man? I know I wrote this one, so you're probably like, what's this guy saying? Yeah.
I think for the most part, when you're doing this, you're essentially reconditioning tissue, and then B, increasing blood flow, and then C, you're just getting things moving.
Yeah,
if you're
absolutely.
if you're doing postural exercises, you're going to get thoracic extension. You're probably going to get some cervical retraction as well, too.
You figured out my secret.
Moving.
Well, anytime I have people do this, they're doing a retraction to neutral. So yeah, man, you figured me out. I'm too predictable. But like I see this presentation, it's typically chronic, more localized neck pain than extremity pain, but can still have like intermittent radicular symptoms. And they just, like you said, like they just need to move. They just need to start to load those structures, just some kind of exercise for that area, right? And this is based off, I mean, we have studies that say, like, if you have neck pain and if you have like pain around the upper traps, rhomboid, whether it's like a peripheralization pattern or not, whatever, if you just start to do some general shoulder strengthening, some cuff strengthening, a little bit of like postural shoulder blade type stuff, it generally has a positive effect on that kind of pain. Like I said, this presentation to me is usually chronic. The localized spine pain, neck pain is greater than the extremity pain, but the extremity pain is still there. And they've been unresponsive or haven't demonstrated directional preference or centralization, right? So it's like, and maybe their mobility is good too. But they just need to start to move, a little bit of strength. It's not quite the motor control category where they have, like I said, a ton of mobility due to some kind of pathology, but they just need to start to use the muscles surrounding their neck. And I'm not saying that they have like a strength deficit per se, or they need to support their neck better because the muscles are weak, right? It's more so like, to me, it's more like reconditioning, just like using that area, giving it exposure to load so the symptoms calm down.
All right, so that brings us to our last treatment.
And Kane, let's hear it.
Oh, man. Nerve glides. Dude.
Oh, man.
Dude.
Okay.
This is just, it's one of those things. We talked about it for lumbar as well, too. But this is one of those topics that when we hit the Wainner cluster and we see a positive median nerve tension test, are you going to give nerve glides to your patient? Like, we're talking about cervical radic. Is it a peripheral nerve issue? And this is where I have a hard time with justifying nerve glides for something like this, because I don't know about you, Mark. I can find positive neural tension tests, and then I don't address it at all. And then I just have them move their spine and it just goes away.
Yeah.
So maybe the issue is not occurring peripherally. Maybe it's occurring centrally. Right. Yeah, so that's one of the things. Sure. It's just one of those things that it's been taught in PT school. It's been taught from previous clinicians and on to their students. And I just have not seen a whole lot of success with it. There are times and cases, just like for any intervention, that sure, it can work, right? Like if it fits, then use it. I have no issue with that. But if this is your first line of defense when it comes to treating cervical radic, I think that this is that's probably a mistake.
Yeah, it just like, I see it almost as low-hanging fruit, right? It's easy to identify. The tests are easy to do. Typically, if someone has radicular pain in that area and you tension that area, usually they will have a positive test, nerve, quote-unquote, tension, right? And then it's easy to address. You just teach them to glide or tension or slide, whatever kind of terminology you want to use. So they said, like you're talking about the cluster, that's easy to do. You can do those tests. It's easy to identify. Same thing with these nerve glides. Like it's easy to do and address. And listen, I'm not here to say that doing nerve glides is wrong or that the approach that Kane and I take is better than people starting with nerve glides. I just think like Kane and I have seen it so commonly where they have a positive upper limb tension test, and you have them do some repeated movements, their pain goes away, and then the test is negative. And you didn't touch the nerve peripherally per se, right? So I think people are quick to jump to the conclusion that when someone has extremity pain and they have a positive tension test, that it's because of nerve tension, when realistically, or at least clinically, what we've seen anecdotally, it's you can get a good response or a quicker response when you address this issues from centrally.
Yeah, the other thing, just to go off your point, is sometimes they have a positive neural tension test. I address their spine, their symptoms go away, and guess what? They still have a positive neural tension test.
Yeah. So determining the relevancy is important as well.
Oh, yeah, for sure. So I think the nerve glides are fine when they're applicable. That's the main thing. But I just think that they're not a good place to start unless I'm stumped. It is the last intervention for a reason for us. On at least on this episode, we've kind of ranked it in order of like, this is what we primarily use, and these are the things that we are, for the most part, using when our system doesn't work and when we're trying to address other deficits that may be causing these symptoms. But to me, they're definitely not my main go-tos. Like, at all. They are there as tools for when I need to use them. I don't know if you share the same type of approach or thought process when it comes to these interventions, Mark, but let me know if you feel any differently about it.
No, I feel very similar, if not the same. It's just, if I've exhausted spine, I'm not getting a response to the extremity with spinal movement. They have a positive tension test, and I just want to get movement in that area. Yeah, I'm fine doing it, right? But I'm only okay doing it if I know I've thoroughly exhausted the spine first. Kane, anything else you want to hit us with?
Oh man, that was like 2-ish hours of cervical spine talk.
Yeah,
I do not have anything else to add for right now. Not for right now. We'll see.
For now. Yeah. So wrapping up, we talked about the Wainner cluster to start with, right? Does it provide clinical utility? Does it give us ideas on how to manage patients? Kane and I, in our personal experience, no, right? We tend to use more of like an MDT style approach where we're looking for symptomatic response based on spinal movement to determine if the extremity symptoms are relevant and if we're able to help the patient provide a lasting change in their symptoms so that they can manage going forward. Other kind of treatments we talked about, or just we talk about snags, just addressing mobility, motor control. We just finished with nerve glide, so I'm not going to talk anymore about that. But what we really want to emphasize is that exhausting cervical spine range of motion, especially retraction, and then adding extension and then transverse and frontal plane movements as necessary, is the key in determining if the extremity pain is from the spine and if the person can manage it. So until you've really given that a shot, you've really worked on retraction, you've addressed the range of motion, you've gone thoracic or lateral if you need to, until that's been done, which usually takes a couple visits, we don't think moving on quickly to other kind of interventions is beneficial or maybe even necessary. So keep retracting. All right. All right, that will conclude today's episode of the PT Good Podcast. Remember to leave us a like, subscribe us on whatever platform you listen to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. Hope you enjoyed. We'll see you on the next episode.
Love you. Bye.